Okay, good morning, everyone. Thank you so much for being here today. I have the pleasure of moderating this session, which is a wonderful collection of speakers, all dedicated to the impacts of maternal fetal health interactions for the correlates of human development. For our first speaker is Dr. Ruth Lathi. She is in the Department of Obstetrics and Gynecology Division of Reproductive Endocrinology and Infertility, and is a particularly exciting person for me to introduce because she's been a tremendous mentor to me as well as an advocate in the realm of genetics and reproduction. So without further ado, let me introduce to you Ruth Lathi talking about a very, very exciting study that I will just say it's currently unfunded. And so if it's exciting to you, consider supporting it.
All right. Good morning, everybody. Thank you, Mary and Neri and Tony and Chrissy and the entire organizing committee for bringing us together today for what I know will be a really exciting and great learning opportunity for everyone. It's my pleasure to be here and talk about a story. I like to tell this. This is a study, but it's also a story. How did it start? And I think it's a really good example of sort of the magic of Stanford and how we can do things that no one else can do here. And you'll see what I mean in a second. So this is the story of TAME. It's a research study that is ongoing right now. And this is really a good example, I think, of how patients drive our research questions. The needs come from the patients. The patients are at the center of everything we do, including our research. And this really was inspired by a patient. So I'm going to start with a case that, kicked off our research study. I don't have any financial disclosures related to this talk, although I wish I did. We have some grant funding here not relevant to today's talk. So just to get things started, this case happened in 2017. We had a 42-year-old patient, her 49-year-old partner presented for IVF, wanting to have a child. And this is pretty typical for us. We see a lot of patients who need IVF for a variety of reasons. Pre-implantation genetic testing for aneuploid is often an adjunct to IVF. It can help reduce age-related aneuploid in pregnancies and miscarriages and can theoretically increase the live birth rate for embryo transfer in certain populations. So she went through IVF. She got 4 embryos. And what you can see here is her embryo report. 1 euploid chromosomally normal embryo and 3 with chromosome abnormalities. And in fact, this is pretty typical. For women over 40, we expect about 60 to 80% of their embryos, pre-implantation embryos, to be aneuploid. And when we got this report, we were pretty happy with telling her she had a euploid embryo. These 3 other embryos were non-viable and would be discarded. That was our standard practice at the time. She sort of had this idea that she really wanted to have a girl and didn't want to discard these female embryos because she felt she wanted at least a chance of having a girl instead of a boy. And let's go to the next thing. How did we approach this? She said, can I just put them all in? If you're going to throw them away anyway, why can't I put them in with the normal embryo? Because I just want this chance. I want to have some chance that I can have a girl. At this time, 2017, there were no live births from PGT diagnosed aneuploid embryos in the literature. We underwent extensive counseling. We talked to our ethics consult. We had a group conference about it. We went through legal. We did a whole bunch of things to try to decide, can we or can't we do this? Ultimately, in the spirit of reproductive autonomy, which drives a lot of our decisions in our clinic, as long as we're within guidelines, we give our patients some say on how we treat them. At that time, the ASRM, which is our governing body or organizing body, had no guidelines for this. They did have guidelines for how many embryos we can transfer. So this is in the background of really a push towards single embryo transfer to minimize the risk of multiple births after ART. However, in poor prognosis cases, especially older patients, they did allow for multiple embryo transfer if the prognosis was poor. So we considered aneuploid embryos. That's pretty poor prognosis. So let's go ahead. So at that time, we were discarding these embryos routinely, but this patient had requested, instead of discarded, to transfer them together. So we decided to transfer them. What happened? Well, look at that. So at 6 weeks, so she got pregnant. We're like, okay, yeah, probably that euploid embryo. Probably going to have a single boy pregnancy, right? At 6 weeks, she had two embryos implanted. On ultrasound, it was pretty clear that it was dizygotic. So 2 of the embryos took. So we're like, oh, that's interesting. Counseling around, maybe one's normal, maybe one's abnormal. Patient was fine with all of that. Went through her pregnancy pretty uneventful. 36 weeks and 2 days is pretty good gestational age for twins. She ruptured her membranes, went into labor, delivered 2 healthy girls. We did a microram on the children. They were both euploid female, and the signatures indicated they were dizygotic. So that means 2 of those embryos that we were going to discard because the PGT told us they were not viable turned into these cute little girls. So currently, these girls are about 7 years old. They're doing well in school. They have no health problems. And we felt like, maybe it's time to write this case up and see what other people think. So we recently published this case report in our flagship journal, which is called Fertility and Sterility. And we got some feedback from the community about what the heck are you guys doing over there? And you probably a few people in this audience are also thinking, what's going on over there? So I want to take a little story back to how did we get here? What has happened since 2017 and what are we doing now? So clearly we have a euploid live birth after a PGT diagnosed aneuploid embryo. What's going on? This is just a case. Maybe it's a 1 in a million. Maybe it's 1 in 10. We don't know. How often does this happen? Are there any other risks to the children? Is this a mosaic that's going to have problems later in life due to other problems? And are these patients, these babies who are born after an aneuploid diagnosis, are they any higher risk than patients who are transferred after an IVF cycle? So as much as we have come a long way in IVF, there are still some residual health risks associated with IVF. So we want to be sure we have a compared to their peers study. So way back, 1978, that's when the first birth occurred, Louise Brown in the United Kingdom from IVF. So IVF is fairly new. Approximately 10 to 15% of people trying to build their families are having difficulty getting pregnant. In the US, 300 to 400,000 cycles of IVF are performed annually. And it's estimated that 1 to 2% of all children born in the United States were conceived through IVF. Although IVF was initially discovered or created for treatment for infertility, it can be used for a wide variety of family building. So we have all of your infertility diagnoses can be treated with IVF, but we also have the LGBTQ community that requires IVF, patients who are interested in fertility preservation. So our applications and our use of IVF have expanded dramatically in the past decades. Briefly for the pediatricians in the room, what is IVF? The core of IVF is that the eggs and the sperm are meeting in the dish, in vitro fertilization. So patients will go through an ovarian stimulation with fertility medications. Eggs are retrieved. The sperm and the eggs meet in the laboratory. Embryos are cultured typically for 5 to 7 days in the laboratory and then transferred back to the uterus. In the past couple decades, we've gotten pretty good at freezing and thawing embryos. So cryopreservation is a pretty big part of what we do. So we'll freeze the embryos. We can store them for days to weeks, decades. And actually, I think that a case report of an embryo that was frozen for over 30 years created a healthy birth, and then he's not too long ago. So when we have the embryos in the laboratory, somebody had this idea of like, well, I have this embryo here. Can I test it for something? right? And this is the pre-implantation genetic testing. I have a few slides here. In 1990, researchers started to explore this opportunity. Can we test the embryos for genetics before putting them back to help reduce the risk of inherited disease? So initially, people were wanting to get the sex chromosome so we could reduce sex-linked diseases. Other single gene testing was performed on embryos. And this field kind of exploded. People started saying, well, I can do that. Can I do this? Can I do the other things? So as genetic technologies have advanced, as embryo culture systems have advanced, as cryopreservation has gotten better, we could pretty much test an embryo for anything we can test a living human on. So with these expanding applications, people, they're with really good intentions, we start to get into these sessions and questions about what should we do? Are there ethical considerations? And are these tests as accurate as these? Obviously, yeah. Pre-implantation genetic testing can be done for single genes, such as SMA, cystic fibrosis, Tay-Sachs disease. It can be done for structural rearrangements and is commonly used for translocation carriers, and then aneuploidy. The really unique piece about aneuploidy is that these are low risk or general population. So PGTM would be for someone who knows they're a Tay-Sachs carrier, right? PGTSR, someone who knows they're a translocation carrier. But PGTA is now being applied to everyone because we're all at risk for aneuploidy. Sure, there's a risk that's related to age, but PGTA is really been applied now to all or even low risk couples. So we have to think about it. Aneuploidy, screening for aneuploidy is a great idea. It is the leading cause of miscarriage and a major cause of age-related infertility. So good intentions. Maternal age drives aneuploidy risk. Chromosome abnormalities are the leading cause of miscarriage and also for a common cause of pregnancy termination. So we have taken this journey with our patients. We have had patients who have tried for 2, 3, 5 years to get pregnant, finally get pregnant, and then have a baby with an anomaly and have to make a really challenging decision about termination versus carrying that pregnancy with the challenges of that. And having walked that walk with our patients, we really are trying to protect them from that, right? We want to give them their best chance of a healthy baby. So the utilization of PGTA has really escalated over time. Let's see, okay, I'll get to that in a second. So age, our number one driver of success rate in IVF, and the largely thought to be due to aneuploidy or abnormalities in the oocyte carrier itself. If you look here on this next slide, the first box, do I have it for you? The first box here on the left is the percentage of embryos that are diagnosed abnormal by PGTA and their direct correlation with maternal age. I just kind of want to highlight that our average patient at Stanford Fertility probably comes in at around age 38. We do have younger patients. We accept all ages, of course, but in this area, 38 is about the median for when we're going to see patients. But we see plenty of women coming to us for their first baby or second or third baby in their 40s. And if you look at the aneuploidy rate in women over 40, about 70 to 80% of their embryos will be abnormal, just like our case that I discussed with you today. Compounded by the fact that as we get older, we make fewer eggs and fewer embryos, there's a risk, which is on the second graph here, that you could go through IVF and all of your embryos are abnormal. So it wouldn't have been statistically improbable for this 42-year-old to have 4 out of 4 be abnormal. And then based on standard practice, all embryos would have been discarded. 0 chance of pregnancy, right? So these two things are in competition with one another. Yes, I want a euploid embryo, but can I get one, right? So just to summarize, there are many benefits of PGTA. Studies do show that per embryo, if your embryo is diagnosed euploid versus your embryo is diagnosed aneuploid, you have a better chance with a euploid embryo. That's pretty well established. It may reduce miscarriage risk, especially in patients who are high risk, like those women who are over 40. And it may decrease time to pregnancy because you're not going through multiple transfers that didn't work. Additionally, we kind of push this single embryo transfer thing a little bit more. So whereas pre-PGTA, we were transferring multiple embryos and having risks of twins, triplets even, after IVF, this huge drive towards transferring one embryo at a time has created some pressure for us to try to pick the best embryo, right? So PGTA does get you there, and we are seeing a single embryo transfer rate in our clinic of about 98% right now, and across the country, it's about 80 to 90%. So we have really done well in that goal. National data shows that about 40 to 60% of IVF cycles, PGTA is performed. Huge proportion of that 300,000 that I talked about earlier today. It's over 70% in women over 35. So very highly used technology. There are some risks and limitations. Does the biopsy impact viability? Or is there a false positive result causing discards? Are there financial considerations? Is the benefit worth the cost? And does it increase your overall live birth for cycle stir? We know that mosaicism can be normal in pre-implantation embryos, which can limit the accuracy of PGTA. So when we're taking a few cells off your embryo, are you getting the cells that are the same as what is going to make your baby? So you can see here that depending on where you take your biopsy, your embryo may or may not be the same as your trifecta DER biopsy. And studies do indicate that about 5 to 30% of embryos are classified as mosaic if you kind of disaggregate them and check them throughout. And as I mentioned, we have our live birth. So there became this shifting perspective. Is PGTA as good as we thought it was, or is it too good to be true? So we have a number in this first case report here was in New England Journal of Medicine, and it was 2015. This was the first time we sort of cracked this code of, are we really accurately diagnosing these embryos? These embryos were diagnosed mosaic and a pre-implantation embryo. They transferred 18 embryos and they got 5 live births. So it's where it's that. 30% live birth, roughly 20 to 30% live birth. People were blown away. It got into New England Journal, so pretty good, right? Mosaic embryos could make live births. And we talked about the error of the biopsy. If an embryo is mosaic, how do you know if it's mosaic if you're only taking a few cells off? Rebiopsy of non-euploid embryos has shown that about 5% of aneuploid embryos, when rebiopsied, are actually euploid. 35% of mosaic embryos were actually euploid, and as many as 65% of segmental mosaic aneuploid embryos were euploid on retesting, highlighting the fact that non-euploid results may be erroneous. We're getting short on time, so I'm going to go a little quicker. So further success, there have been a number of pretty large case series. The limitations being that these are self-reports, they're registries, right? So a little bit of retrospective data that we're looking at. People report what they want to report, right? We don't know the numerator and denominator, but to date, the largest case series has 488 live births from mosaic transfers, not aneuploid. And only one of these had significant abnormalities on ultrasound, leading to termination. 3 of the 250 patients who had prenatal testing had the mosaicism confirmed. So about just a little over 1%. And then we did a cost-effective study here where transferring a mosaic embryo is probably going to be more likely to lead to success than another fresh transfer. So current state, mosaic, many clinics still to this day do not allow transfer of mosaic or aneuploid embryos and have policies to automatically discard these embryos. And data is limited by self-report and registries with minimal neonatal outcome. Last year, I was interviewed by Time Magazine about our study because there were never class action lawsuits that came out. Because of these case reports, some of the patients were starting to sue their clinics because they weren't allowed to do these abnormal transfers. And so in addition to that, a number of other news outlets got wind of all of this. It was in New York Times, a number of blogs, and a series of interviews from there. So after we were shocked by the outcome of our case, we decided maybe we should study it. So in 2017, we actually began our TAME study. And our TAME study is enrolling patients who present to us requesting aneuploid transfer and following pregnancy outcomes like birth, obviously neonatal and childhood outcomes up to age 5, comparing to euploid peers. So age-matched patients who did a euploid transfer compared to those who did an Aneuploid or Mosaic transfer. I'm going to get there, I promise. I just want to summarize as we get to the end, and I hopefully we'll have time for question and discussion later, that this study that we have right now, the TAME study, is really an improbable story driven by patients. We have patients coming from clinics all over the country and the world because they're wanting to participate in this study. It's an example of our multi-specialty collaboration. We have maternal-fetal medicine, genetics, ethics, really working together on developing the right protocol for the patients in response to their desires and demands, while still being responsible clinicians and researchers and sharing our outcome with the world. To date, we have 120 patients enrolled. We're still open for enrollment. 2/3 of these patients did their IVF clinics cycles at other clinics and transferred their care to Stanford for the opportunity to transfer their embryonic embryos. There are no financial incentives. There's no funding at all, but there's no financial incentives. Patients are coming and flying to California and transferring these embryos because they really, really, really want a chance. And for every patient that has enrolled and done a transfer, there are 2 or 3 that have come and explored and done the counseling about the study to learn more about it. So patients really, really want this chance. And, I'm really proud that here at Stanford, we've been able to offer that to our patients. So future directions, obviously we need more than just, was the baby born alive? We want longer term follow-up, large prospective studies, and just more learning about how we can optimize our pre-implantation genetic testing. I really want to acknowledge the, Stanford community as a whole, the reproductive genetics team and research coordinators. This is a lot of work to kind of field and bring in patients from all these other clinics. Christy Tise, Roni Mazzoni, Ali Boyd, Sarah, Sophia, everyone who's here, Don Bernstein, and many, many more have helped us get these types of initiatives off the ground. So I just want to thank you for your attention. If there's time for questions now, we'll take it. And I'll leave our contact information up here if you have questions or anything. Please reach out. Thanks for your attention.
Yeah, great call. I was just wondering, within the Mosaic embryos, when you do the disaggregation, is there a certain embryonic cell type that you see is more frequently aneuploidy or more susceptible to aneuploidy?
So just in case you guys didn't hear, are there certain cell types that are more susceptible to aneuploidy? I think there is a little bit of tendency for abnormal cells to be shunted out to the placenta later in pregnancy. But we do see, it's hard to say for sure in the early pre-implantation stage if that's also true. Yeah.
Question.
Thank you, Ruth. This is a great success story. In science, we're trying to minimize randomness in this situation. There was some randomness here that led to a good outcome. Can you just say a few more words about the use of trophectoderm cells, which increase the randomness because of the confined placental mosaicism, and the placenta is much more tolerant to abnormalities, versus biopsying the inner cell mass in the accuracy of the pre-implantation genetics? So whether you use a cell from the placenta, from the future placenta, or use a cell from the future embryo.
Exactly. So the two cell types, the hard part is we can't biopsy a growing embryo and hope it will survive because of the few number of cells. And that disparity, that discrepancy is really the root of all of this, plus the limits of the technology. We're doing DNA amplification on very limited number of cells. So is it true mosaicism or is it just amplification error or, other technological limits? So people have gone in the field from calling them mosaic to just saying intermediate copy number because we don't know if it's truly the cells or the technology. People have tried other sort of like non-invasive testing of embryos. So like looking at the chromosomes in the culture media, for example, kind of like an early cell-free DNA kind of thing. It is no more accurate, right? It still has a lot of errors. The highest correlation is still the trophectoderm to the inner cell mass, but it's not perfect. So I think we need more studies to know how often there is that discrepancy and how we can improve our testing to help our patients.
All right, one more round of applause for Dr. Lathi. Okay, our next speaker is Nima Aghaeepour. He will be talking today about AI-powered integration of maternal and child health. And without further ado, he will present his exciting research.
Good morning. Thank you for the opportunity to speak with you today. My lab works on the interface of maternal and child health. We work on integrating various data modalities, including biology, clinical data, structured, unstructured, all of it, to build holistic models that understand the context of maternal and child health and can be used to not just predict one disease at a time, but to guide the entire course of patients' care. There is no better place to talk about why healthy mothers are important for healthy children than chorioamnionitis. For those of you who are not familiar, chorioamnionitis is an infection that happens towards the end of pregnancy, and it has grave consequences for both the mom and the baby. Starting at the top, you often see amniotic fluid abnormalities. Going a little bit further down, you see an increased risk of cesarean delivery and various other complications. The x-axis is odds ratio on a log scale. So these are pretty dramatic odds ratios. Going a little bit further down, you see maternal outcomes, including maternal sepsis, ICU admission, and so on. And further down, you start seeing neonatal outcomes, including a pretty dramatic increase of 8-fold in neonatal sepsis, but also a pretty dramatic increase in bronchopulmonary dysplasia and other complications. We really need to deal with this on the maternal side to give these babies a chance at survival. It happens that my own daughter was born to a chorioamnionitis infection. And this was just 5 minutes away from where we are standing today. And it was a rough episode, several weeks in the hospital, and it was complicated. She's doing fantastic, nothing to worry about. And thanks to Dr. Virginia Wynn, who is winning the Visionary Award later today. But I remember asking the OBs at that time that how much earlier should we have predicted this for you to be able to do something about it? And the answer, at the time at least, was 2 hours. If we can predict this 2 hours faster than physicians, we'll be able to use antibiotics and reduce the risk of chorioamnionitis, hopefully prevent the prior surgery and not deal with the downstream consequences. Because of the unique infrastructure that Stanford has for data science, we were able to build models that do exactly that look at all the vital signs, all the EHR data, and try to predict chorioamnionitis. Here we're looking at how long it takes for the ACOG criteria to make a diagnosis, how long it takes for a physician, and how long it takes for our AI to make a diagnosis in hours since the patient was admitted to the hospital. And you can see that the model is already 15 hours or so faster than the average physician. This is pretty promising. They asked for 2 hours, so if you're 15, 20 hours faster, that's pretty fantastic. We did a simulation study. Oh, I guess this was This was built in a model based on 6 years of data and then validated using a separate data set still from Stanford, and that worked great. As we speak, we are working on validating this in other hospitals independently. To build on this, we did a simulation study where we would show these vital signs to a number of OBs and give them a big red button and tell them to press it whenever they think the patient has chorioamnionitis and they want to start antibiotics. These are not just OBs from Stanford, they're from all over the country, and you can see that on average it takes them 30 hours from admission to make a diagnosis, and they are about 70-80% accurate. The AI model is up there. It's close to 100%, I believe 98% accurate. And again, it's 15 hours or so faster than the average OB. You see a couple of humans up there who are close to AI. To my surprise, it turns out that those are the most experienced OBs that we work for. Generally, we think that the younger people who are seeing a lot of patients are pretty good. It turns out that at least with this limited sample size, the highly experienced people are pretty good at making this diagnosis and then get close to AI, but not the average person. This is a highly collaborative work led by Tommy James, but on the team you see neonatologists, you see OB anesthesiologists, you see OBs, because it reflects the true diversity and interdisciplinary collaboration that you need to address a problem like this that crosses multiple fields. Here on the y-axis, you're looking at risk of chorioamnionitis according to AI. The blue ones are the ones who were never diagnosed and never got antibiotics at Stanford. The red ones are the cases. There are these patients up there above the, I don't know how to point to something here. Okay, that's not good. So there are these patients above the blue box spot who are technically controlled, who never got antibiotics, but the AI thinks they are at really high risk of chorioamnionitis. And thank you so much. And it turns out that those patients are histologically confirmed after birth to be chorioamnionitis patients, but before birth they were never diagnosed, they never received treatment. And this really highlights the AI's ability to go beyond current standards and guide therapeutic decisions that otherwise would have been missed. And histologic chorioamnionitis is linked to a 20% increase in risk of cerebral palsy as well as a wide range of other complications. This gets even more exciting because it turns out that if we limit the model to only measurements that can be captured using a commercial grade wearable device, for example, an Apple Watch, the model still works pretty well. It becomes a little bit less accurate, but still far more accurate than humans. This enables us in the long run to scale this to low and middle income countries, to all kinds of places where we can't have clinical grade vital sign monitoring and still get good diagnosis that can be moved, that can be used for guiding therapeutic decisions. His work on wearable devices is generally pretty exciting and one of the core themes in our lab. In another study working with Sarah England and colleagues at the Prematurity Research Center in WashU, we used a data set of about 1,000 women where we had wearable devices on them and we were tracking them throughout the course of an entire pregnancy. And we used an AI model with inception clocks and a couple other fancy ideas to basically ask the AI, can you look at a patient's wearable device data and tell us how pregnant they are? On the x-axis, you're looking at gestational age. On the y-axis, you're looking at estimated gestational age by the AI. In the right plot, you see that red group of patients. Those are patients who are not very pregnant, but to the AI, they look very pregnant. And the blue patients are very pregnant, but to the AI, they don't look that pregnant. They're still moving a lot, they're sleeping well, they don't look that pregnant. It turns out that the blue patients are at 50% decreased risk of preterm birth, which is quite remarkable if you compare it to any kind of pharmaceutical intervention. And the red group are at 33% increased risk of preterm birth, and those p-values are very strong, clearly. But this could be confounded. It could be that we have people who are generally moving more, sleeping better, they are healthier, and it happens that also they have better outcomes. Others, including Tony Viscore and other scientists, have shown that physical activity and sleep are linked to less inflammation. We have known for a while that lower inflammation levels are linked to preterm birth. There is a chance at causality here. It's possible that physical activity and sleep can modulate inflammation and through that affect preterm birth. But there is no way to know that for sure because all of that could be confounded. So we tested it. We ran proteomics on the red patients versus blue patients at the first trimester of pregnancy, and we saw no differences. So these people are going into pregnancy the same. In the third trimester, they are very different from each other. This suggests that it's possible that these people go into pregnancy the same, but because their physical activity and sleep patterns are different, they come out biologically very different. And of course, the red group has increased risk. So the next step for us is to run an RCT to actually confirm this, to use interventions based on physical activity and sleep, measure biology, and track changes in outcomes. Continuing on the theme of connecting maternal and newborn health, here is another project where we used large claims data sets to link maternal medications to neonatal outcomes. In the center, you see a network of neonatal outcomes, and in the larger circle, you see various classes of medications and how they are linked to neonatal outcomes at a large scale. This is generally a difficult problem to study because of the obvious limitations of studying medications during pregnancy. So it's exciting to be able to leverage like large data sets like this to look at correlations. Some of the most exciting hits are on the left side, where we are looking at ondansetron and its connection to our bronchopulmonary dysplasia and respiratory distress syndrome. This was unexpected for us to see. It's a new connection that was not reported previously, but also it's possible that it's confounded by any number of factors. We used computational techniques to account for those confounders, and this connection remained pretty strong, but still it's possible that there's some kind of unobserved confounder that is driving this. We used publicly available data sets and knowledge graphs to look for a connection between ondansetron and bronchopulmonary dysplasia. And it turns out that that connection goes through IL-1 beta. And as I was speaking about this at Stanford, it turned out that Dr. Prince's lab has been studying IL-1 beta in the context of bronchopulmonary dysplasia. So they were able to take this finding to animal models, and that shows my level of understanding of animal models, but they were able to take this into animal models and confirm that this connection between ondansetron and bronchopulmonary dysplasia is not just confounded by killing off factors, that it is actually causal. And there are several studies planned to build on this. Going back to preterm birth itself, preterm birth is defined as gestational age under 37 weeks. As a computer scientist, I always had to go on Wikipedia every time I look it up, but I assume that there is some kind of reason behind this, that there is a medical or for at least biological reason. It turns out that like most other thresholds in medicine, there isn't. So we looked at redefining that threshold using data. Again, at Stanford, we have two cutting-edge hospitals with really strong information systems. We were able to use AI to build a bridge between these two hospitals. On one end, we have a ton of information on the mothers long before they were even pregnant. On the other hand, we have a lot of information on the newborns. And that linkage has turned out to be a really powerful tool. By linking these two data sets, we were able to predict various neonatal outcomes. For example, this particular patient got sepsis at 1 month old, they got bronchopulmonary dysplasia at 2 months old, and we predicted all of those. They didn't get cerebral palsy or neck, we predicted that correctly as well. But the exciting part is that here 2 weeks before birth, we already got almost everything right about the patients. They're not even born, and we already know what is going to happen to them. This was validated in a second hospital independently, and then we started getting pretty excited about it. Here is a network of the top features that the model is looking at for predicting necrotizing enterocolitis. We're looking at history of insulin use and antihypertensive use for the obvious reasons, gestational diabetes and hypertension and so on. But it's looking at also history of chemotherapy. This is not active chemotherapy, it's chemotherapy from many years ago. And if what you care about is gestational age at birth and preterm birth in 37 weeks, this may not be that important. But if what you care about is necrotizing enterocolitis in the baby, this is absolutely important. It's looking at a wide range of other factors, including social determinants of health, like incarceration, homelessness, tobacco use, factors that I didn't even know are captured in RDHR until I saw these plots. So at this point, I started exploring how can we use this to change therapeutic decisions in the hospital. The project went through biodesign, Spark, OTL program called HITS, and I want to again thank MCHRI for being a sponsor for both biodesign and Spark that enables this type of work. And in particular, I want to acknowledge Janine Firich, who was very critical at that point in my thinking and in figuring out how to go beyond predictions and get to actionability. What came out of this journey of going through biodesign and Spark and a few other areas was a project that takes these predictive models and focuses them on actionability. Here's an example of that. When these kiddos are born prematurely, they don't have the gastrointestinal system to process breast milk. You have to put them on these IV bags for their nutrition. But what goes into these IV bags is reactionary. We basically say, hey, it looks like your sodium level is too low, let me give you more sodium for tomorrow. It's also expensive. You need a physician to place an order. A dietitian may or may not approve that. If they don't like the calorie intake, it will get kicked back to the physician. They'll adjust it. It goes to the pharmacist. If everybody is eventually on the same page, it has to be made in a sterile environment and shipped to the hospital. And these TPN bags are also the single largest source of error in the NICUs. Multiple independent studies have shown this. So we took 10 years worth of DPN prescriptions and we plugged it into that previous model that I was talking about. This model has the advantage of knowing about what's going to happen to these patients 3 months down the road. So it can be proactive instead of being reactive. The model also was able to reduce the complexity of TPN to just 15 prescriptions. So you can mass manufacture these 15 prescriptions instead of making them one at a time, dramatically reducing costs so it can be used in low and middle income settings and reducing the possibility of mistakes and errors. These are all very big claims. So we did a pilot study at Stanford. We took 180 patients and we showed the real prescription and the AI-generated prescription to a number of neonatologists and nurses and pharmacists and dietitians. And we asked them to tell us which solution they think is a better fit for the patient. This is Derek Kasparov playing against Deep Blue. I was a little kiddo watching this many years ago. And it was the first time that a world champion was losing to AI. And Gary's body language speaks for itself. I'm going to show you a picture. This is a spontaneous real picture from our very first pilot study. And from body language alone, you can tell which one is my good friend Jonathan Reese, who is a neonatologist here, and which one is our AI fellow in the lab running this thing. So it didn't go over that well for the humans. It turns out that humans significantly prefer the AI-generated solution to the real one. And it also turns out that when humans and AI disagree with each other, risk of necrotizing enterocolitis goes up by 2.5-fold. Risk of mortality and cholestasis and a bunch of other factors also significantly up. And when we chart review those patients, we often find mistakes by humans that are inconsistent with generally accepted guidelines. This was sent to a second hospital, and we didn't have access to their data. They ran everything independently, and they got the same results. Another aspect of this data set is that nutrition in the NICUs is not limited to TPN. We have looked at how these patients transition off of TPN and into mother's breast milk. And it turns out that patients whose last day of TPN is significantly different from mother's milk composition have significantly worse outcomes. The patients whose last day of TPN is similar to milk have better outcomes. This shows how we can learn from biology to optimize parenteral nutrition. Next steps for the project is a pilot study in the NICU, which is working out pretty well, and our EHR integration is complete, but we don't want our physicians to rely on AI, so now we are using AI to guide education of physicians in parenteral nutrition. We are expanding this to adults. We are starting with bone marrow transplant patients, but we are quickly going to expand to other areas. And this is important to highlight here because we often hear that pediatric areas are too small and it's not a big enough patient population for innovation. We often have to adopt innovations from the adult space. That is not true. It is absolutely possible to innovate in pediatrics and then bring those innovations to the adult hospital as well. And finally, we are working on AI models that can integrate milk fortification formula, the rest of nutrition into the same models, and expanding this to PGI as well. So far, we've been talking about prematurity itself and survival, but it turns out that kids that are born premature and survive the NICUs and graduate from the NICUs still have long-term adverse events. Here we're looking at a cohort of 50 years old where we knew which ones were born prematurely. And it turns out that in this cohort of 50 years old, there are significant morbidities that are elevated in the groups that were born prematurely. We can build a machine learning model using proteomics data in these 50 years old to quote unquote predict which ones were born prematurely. That's pretty scary. You're 50 years old, and from your biology alone, without knowing anything else about you, we can tell if 50 years ago you were born prematurely. Let's call that model a proteomics index of prematurity at 50 years of age. It turns out that that proteomics prematurity index itself is more associated with various diseases than birth rate or gestational age. In this case, we are looking at chronic kidney disease, and with proteomics index of prematurity at 50 years of age is significantly more associated with that than birth rate. This proteomics prematurity index is also affecting almost every organ in the body. So what we are doing at Stanford now is that we have found these log books. This is a real picture. We have found these log books from 50 years ago with Dr. Stevenson's beautiful handwriting in them. We are going to digitize all of these, figure out who was born at Stanford's NICU 50 years ago, so we can bring them back to the hospital, get a blood sample, give them a wearable device, and start tracking them, and start learning about how to take care of these patients after they have graduated from the NICUs. We have also done a ton of work leveraging all the omics technologies that are available at Stanford to understand maternal health. And through a long journey, we have been able to work with the Gates Foundation to build models that can predict preterm birth using a single blood sample in the first trimester of pregnancy. And that model is associated with all kinds of metabolites, various proteins that are classic inflammatory pathways, and that's all great. We can predict who is going to be giving birth prematurely. But these models, excitingly, are also associated with neonatal outcomes directly. For example, we can predict Bailey scores and motor and language and cognitive performance scores of these children 2 years after birth. Not only that, but we can use unique linkages between electronic health records, metabolites that are used regularly for newborn metabolite screening, and various imaging and text modalities to predict diseases like necrotizing enterocolitis, bronchopulmonary dysplasia, and various other factors there. This is now going to expand to other models, again integrating biology and electronic health records, looking at acute kidney injury, heart failure, 2-year neurocognitive outcomes, growth trajectories, and a broad range of other factors that we are investigating now that we have this integrated data sets. Finally, a big area of focus in the lab moving forward is integration of notes, electronic health records, imaging modalities, biology using AI. And we have already shown that by integrating omics data and clinical data, not only can we make better predictions, but also we can discover stronger biological insights. This is work by Samson Nakaraso, who recently got his PhD and graduated, but the next generation is already here, and this is going to be a big area of focus for the lab moving forward. I'll stop here and thank numerous colleagues who have been part of this journey, in particular all the lab members and alumni, my colleagues in anesthesia, including Brian Bateman, Chris Goodlear, Martin Ants, and Brandon Carballo, various colleagues in MCHRI, PEDS, OB, including David Stevenson, who first brought my attention to this field and has been an amazing friend and colleague and mentor, as well as Mary, Carl, several other folks in the audience, and Jonathan Reese, who has been a great partner in many of the studies and has been helping us with various aspects of the NICU. And all the folks in the lab, I will start here by showing you a list of abstracts that you'll see from the lab. I was careful not to talk about any of these projects, not to steal their thunder. In particular, you will see Leo's very interesting presentation later today about predicting out-of-range vital signs, as well as a wide range of other posters that you'll see in the poster session. Thank you very much.
Thank you, Nima. Just for time purposes, I think we'll let you take questions during the poster session. So those were two terrific talks from people here at Stanford, and now we'd like to introduce some external invitees to talk about their research at other institutions. So next up is David Rowitch. He's a professor of pediatrics and neonatology and associate director of basic science and translational research at Cedars-Sinai Medical Center, speaking to us about genomic insights into cerebral palsy and origins of human disease. Thank you.
Great. Well, thank you very much to the organizers. It's really exciting to be here as part of the MCHRI 8th Annual Symposium. Some really exciting ideas that we've heard in some of the initial talks, and I'll be kind of carrying on to look at how genomics is going to be an important part of our practice, and also how we can think ahead to predicting health risks, maybe preventing diseases in the future. So I'd like to talk about the role of genomic sequencing in diagnosis of intensively ill children. This will be studies based in the United Kingdom, where I've been the head of pediatrics for the last 10 years at the University of Cambridge. How we've advanced our understanding of cerebral palsy from the classic notions of what that disease was caused by, and a new study called Bloom, which is about this idea of can we predict distant health risks, and also educational disabilities earlier to intervene. So as a neonatologist, these would be the major neurological problems that we would be dealing with. Kids that will go on to develop cerebral palsy, a global problem. In the UK, 10,000 very preterm babies, they will have cognitive deficits, and then in adolescence have psychiatric manifestations. And about 2,000 babies admitted per year in the UK with seizures. So that's a kind of a nice way to entree how we've taken a stratified approach to the management of these children in the NICU. People will be aware of the UCSF Neurointensive Care Nursery. I know Sonia here has really helped to bolster the NeuroNICU at Stanford. This is a multidisciplinary collaboration between neonatologists, specialized nurses, radiology, and neurology. So we co-manage care, and we're showing how we can improve outcomes in a variety of different conditions. But it also allows us to stratify care, and also to mention that Cedars will be opening its own NeuroNICU, the only one in Los Angeles, next year. So what does stratification of care mean? So let's take this example of seizures, and this is a little video of a baby, and I can ask you the question, who thinks this baby is having a seizure? And you could tell it is a video. There's a nurse kind of moving in and out of the frame. The saturation is 98 to 100%. There's no DSATs. And the clue is, look at the EEG at the lower right. That's status epilepticus. So as many as 50% of seizures in babies are subclinical. So you must do continuous video EEG monitoring. Otherwise, you just won't catch it. You won't know what you're trying to treat. Other pieces of kit you want to have would be a MRI-compatible incubator developed by Jim Barkovich at UCSF. This is now a commercial version shown in the slide. Babies inside the MRI, the coils right by their head. You get better resolution scans for, let's say, the 45-minute research sequences you might want to run. We would also do metabolic screens looking for those types of disorders or infection. And then we're trying to stratify into different classes of injury, like hypoxic ischemic encephalopathy or stroke, brain malformations, or rare genetic diseases for which, genomics would be the great tool to be able to use. Not too available about 10 years ago at the bedside. And it was one of the reasons why on sabbatical, I went to the UK to work with Genomics England Limited, 100,000 Genomes Project, to ask the question, can we put whole genome sequencing as a diagnostic into NICU, PICU, neurology clinic? What's the return rate, and which should these be tools that are just generally available? And you'll see in the study that we recruited 521 kids and their parents, trios from these clinics. And if you break it down by, let's say, NICU, in the NICU, about a 25% diagnostic rate. So around 1 in 4 kids in NICU that would have a genetic condition. So what you'll get a sense for reading those statistics. It's 1 in 3 kids in PICU, and in neurology clinic, it's about 1 in 2 kids. A lot of genetic diseases drive children to hospital or specialist care in pediatrics. And we start to see these numbers, it really makes the case that we should have the REF tool, whole genome sequencing, available to make the diagnosis. Within 6 months of a study being published in the UK, the NHS made it available across the entire country. So NHS has some real interesting capabilities. It is a socialized, single-payer system, and it can scale some of these new techniques very rapidly. So what's the impact for seizure diagnosis? This slide now shows the actual diagnoses that we made in kids that had genetically driven seizure disorders, and the turquoise shaded ones are the conditions for which there is now precision medicine. That means that for a particular cause of seizure like KCNQ2, you'd switch the baby from Keppra or phenobarbital to carbamazepine with a much better therapeutic response. So already about 1 in 5 genetic seizure disorders would be eligible for precision medicine. Again, another reason you want to have those data quickly to be able to help care. And now there's a lot of new stuff going on, like the Stokes-Gervais study. This will be the first gene therapy for an epilepsy autism syndrome against SCN1A. That study is now operational at UCSF. It is going to be started also at Cedars. So exciting times, really, when what genetic diagnosis can help us provide for our patients. So for cerebral palsy, classic disease, probably the disease for which neonatology was started in the 1960s at places like Stanford and UCSF and around the world. This is a lifelong and non-progressive condition that affects body tone and can be associated with cognitive impairment. Affects around 19 million people globally and about 1 million in the US. We've thought always that this was caused by brain damage, either in utero or at the time of birth, maybe a botched delivery. And of course, that can result in lots of litigation, but I'll just share with you how our new appreciation that genetic drivers can also appear as cerebral palsy, and that's a new insight that we can use. And this will also lead to the question about developmental programs that are affected in the brain by cerebral palsy. Sort of the area that my lab has taken over many years, looking at the glial cells in the brain. So the circle shows sort of like what my lab works on: developmental biology, mapping that against human genetics and diseases to try to get new insights. And we focused on the cell called the oligodendrocyte, which you saw in that little video, was sending a nerve's impulse along its axon. The nerve is sending the impulse. It's covered in these little white blobs, and these are the insulating myelin segments. And they're very important for the maintenance of neurological function, affected in diseases like multiple sclerosis, but also prominently affected in a number of newborn brain injuries. So I wanted to illustrate that in both the context of a preterm infant on the top who might have diffuse scoliosis indicated in turquoise. All these gliotic regions are the communication highways of the brain. So if you imagine now you have abnormal function of those areas, you may be compromising circuit function. Long term, we can see in babies that have had severe brain injury, ex vacuo, hydrocephalus, and hypomyelination. For full-term babies, they may be subject to stroke, which is a large vessel occlusion. About 1 in 2,800 babies in California have this condition. That's compared to 1 in 5,000 adults that have large vessel stroke. So it's a relatively common condition. Um, and also a diffuse hypoxic ischemic encephalopathy, where there would also be diffuse white matter injury. And Steve Miller at UBC has been really highlighting the role of glial impact in those diseases. So now, where my lab comes in is to define some of the transcription factors that determine the building blocks of glia, and those would be oligodendrocytes and astrocytes. We help define the olig gene family. They're expressed in multipotent progenitor cells that go on to form these fascinating oligodendrocyte precursors, cells that are nomadic. They travel all around looking for axon targets. They can proliferate, and they're really responsive to disease and developmental challenges. They will find an axon bed, and they become a pre-myelinating oligodendrocyte. And then once they've engaged with the axon, they start to form those myelin blobs. And you think, okay, that's easy. 1 step, 2 step. But actually, this is the most prolific biosynthetic feat in biology. This oligodendrocyte becomes the largest cell in our body with a 7,000-fold increase in cell surface area. This is the output of 1 oligodendrocyte. So now you can imagine a tiny little cell that's, probably pedaling really fast or something, and, multiple axon segments, and that it's sending out myelin protoplasm to. So this, you can imagine, is a very metabolically stressful transition, and it starts to explain why when we look at white matter diseases, we see that they're blocked from myelination. First observed by Bruce Trapp and colleagues in multiple sclerosis, that you'd see precursor cells in a demyelinated MS plaque not myelinating. They're sort of blocked here. And with Hanna-Kinney, we also showed the same occurred in neonatal wet matter injuries. We find these precursor cells, they're not, dying as we sort of used to think. The oligodendrocyte maybe just kind of like fell apart. No, they're blocked in this very smart way because this transition needs to be supported by optimal environmental circumstances. So now we can start to think about what are the agents that block transition from a pre-myelinating to myelinating oligodendrocyte, and work with Steve Fancy when he was in my lab, identified the WIT pathway as a signal pathway that can block this transition. What is the WIT pathway? People here know from work of Rolnis that has been a pioneer in defining this pathway, but in the off state, there is a central signaling molecule called beta-catenin, which becomes degraded and has no real signaling impact. In the context of a Wnt ligand binding to the co-receptor complex, this now stabilizes beta-catenin in the cytoplasm. It moves into the nucleus. It activates gene targets, and axin 2 is a good readout of a cell that has active Wnt signaling. So we've modeled this genetically with activation of beta-catenin with removal of 2 inhibitors of the pathway, APC or axin 2, all of which would result in increased Wnt activity. And what we see is that will block the transition from a pre-myelinating to myelinating oligodendrocyte. So what about in neonatal white matter injury? Well, Steve, looking at cases of paraventricular leukomalacia or newborn preterm white matter injury or hypoxic ischemic encephalopathy, would find in those areas of damaged white matter, axin 2 expressing cells that also co-express OLIG2, meaning that they are oligodendrocytes that have active Wnt signaling. Our prediction would be those cells are going to be blocked for myelination, and that could account for some of the hypomyelination that might be occurring in that lesion. So to summarize this very quick intro to Wnt, maturation arrest and not-cell death characterizes the oligodendrocyte lineage in neonatal wet matter injury. Activated Wnt signaling inhibits myelination, and we see this in neonatal white matter injury and even some cases of CP, where we can also further say these are in a high threshold state, predicted to fail to myelinate. And I mentioned, so for CP, that some individuals may have genetic lesions. This is some of the evidence that's come out over the last 5 years or so from many places around the world, showing if you use whole exome sequencing and whole genome sequencing, that you find driver mutations. Let's imagine hereditary spastic paraplegia or TUB2 mutation, ones that would be known to cause spasticity and also movement disorders, and they're showing up in cerebral palsy patients. So you could think of it 2 ways. They're really patients with a genetic disease that have been misdiagnosed as cerebral palsy. Or maybe there are patients who are susceptible to development of cerebral palsy. They have a genetic predisposition. Now they've gone through difficult delivery. That combo now results in a phenotype or manifestation that gives them the severe problems. So here are some studies that I've just picked out, depending on your cohort, depending on how you select them. 11 to 33% of people with the diagnosis of cerebral palsy found to have a monogenic condition. Now, if you're very good magnifying glasses, you'll see that one of them is beta-catenin. And so this is now also very interesting. There are 400 variants of beta-catenin, that same signaling molecule that I told you about, reported in cerebral palsy patients. Also, weirdly, they are present across the entire N-terminal domain, the 12 armadillo repeat domains, the TCF4 binding domains required for its transcriptional effects, and also in the poorly characterized C-terminal region. So all of these associated with cerebral palsy questions, this now once you put your basic science hat on to ask, what's going on, can we start to now stratify these mutations and start to get insights that would be patient-specific and helping us to understand the biology of cerebral palsy. So with Melissa Gammons and Christina Antonou, we are now screening, these are just a set of missense mutations of beta-catenin from cerebral palsy patients in a typical top flash assay. In top flash, this would represent 100% is the activity you get from a wild type beta-catenin. And now you can measure whether something is a inhibitor of the pathway or activating, and then characterize them in respect of which activity. So they're not all the same. My assumption was maybe these were all loss of function mutations, but they're not. And now we're taking individual ones and then putting them through additional screens, which we can do in flies with Yuko Bellin, in fish with David Lyons, in Xenopus with Mr. Makoka, all animal systems that we can use to sort of assess the functional impact of these variants. And my lab will be doing this in mice. So I think it's it's an interesting case where now we can use a sort of undiagnosed disease platform approach and collaborating labs in the basic sciences to get insights into what are these mutations doing. So I think we've seen now a real breakthrough in the diagnosis of CP, and the biggest question is which CP patients should get offered whole genome sequencing. These opportunities for modeling genetic forms of CP are very exciting, and then gene therapy, could follow from basic science understanding. Okay, so moving on now to the Bloom study in the last 5 minutes or so. This slide is I'll leave it up a little bit longer. It's kind of imaginative, but it might be a really good MCHRI slide, because what is really asking the question, to what extent would events in the early life course, have manifestations at much greater stages of life as a child, in middle age, or even adulthood? When can we first, start to detect origins of heart disease? Then we would know when to screen. You heard about that in just the last talk. AI might be helping us to say, so there are certain time points that are very useful for predicting or finding the earliest manifestations of a disease. With two Cambridge professors that I want to highlight, Sam Bajati, who's looking at this using a multi-omic approach where by studying the sequence of DNA variants that are acquired during development, he's able to trace back the origins of Wilms tumor to a mesonephric duct in the 17-week-old embryo. Catherine Aiken, who is an obstetrician who does deep phenotyping of the fetus, but now we are coupling that clinical data to the national educational record in the UK. So we can now look at in utero conditions that result in learning disabilities. And I'll come back to that point. So now just imagine you've got a system, a lot more joined up than the US, where we have genomics, we have the health record, and we have educational record. And that is the background for the Bloom study. It's a 1,000 neonate cohort study. Inverting the paradigm, we're going to look at kids that are higher risk, and you heard about that just in the last talk, why babies from NICU are at high risk for a variety of health conditions. We will be providing diagnosis, so this will actually be providing real-time benefits, linking to health and education, and also we're thinking ahead to an international consortium starting with Singapore. The primary outcome is one with real-world impact. It's called school readiness, and at age 5, every child in the UK will have completed a year-long assessment across 17 domains of development to determine if they're ready to enter mainstream school. And so we can link to this data nationally. Now, the children who don't fail, who don't succeed in this, or I guess fail their school readiness exam, go on to have poor social skills, reading, math, and physical skills in the long term. I didn't show this other data, but poor physical and mental health, higher rates of incarceration, deprivation, and premature death. So here's an H5 outcome with profound implications across the life course, and something that I think we need to study much more carefully, especially since our data shows that 1 in 3 babies coming from NICU, this includes level 2 and level 3, fail school readiness versus 1 in 6 in the general population. So about twice as likely to fail school readiness. With Singapore, we now have a funded collaboration. These just highlight some of the similarities between the East of England and Singapore population. We bring in a lot of ethnic diversity because of the composition of Singapore, but we both have educational systems that track school readiness. And we're thinking ahead to including low and middle income countries as part of a consortium. And Annette Nakamuli from MCHRI University in Kampala will be our scientific board chair. So this was the brief introduction to balloons. Novel life course cohort paradigm for children at risk. In the short term, we're going to try to improve diagnosis and provide direct benefits. In the long term, we'd like to be able to better highlight the kids coming from NICU using genomics, multiomics, and other markers that would be at risk for failing school readiness in time that we can intervene. And interventions can be done at ages 2 and 3. We're working with the Department for Education in the UK to actually develop that implementation plan. And we will hope to further our understanding of human neurodevelopment, learning attainment, and disease origins. So this is the Bloom's map. Singapore is on board with funding from the Wellcome Trust. Cedars will be developing a Bloom's site, and we look forward to joining with other groups. Here are some of the people involved in studies. I'll stop for questions if there's any time. Thanks for your attention.
David, amazing. So in terms of this idea about genetics and environment for cerebral palsy, it sounds like you have a genetic basis for it, but does it predict what are the environmental influences around, for example, the Wnt pathway, signaling pathway that might be predictive or helpful for neonatologists to basically predict and prevent the disease in the population?
Right. It's a tricky one. I'll just give you maybe one example that I didn't really focus on some of the genes that you see in the cerebral palsy cohorts. We're developing gene panels for those now. Many of them are collagen or vascular integrity factors. And now if you think, oh, here's a baby with neonatal stroke, as a CP, wouldn't it have been nice to know that? Or it does kind of put things together. So it could be the stress of delivery, which we know is associated with the neonatal stroke, and this predisposition helps to explain why this particular baby ended up having that kind of clinical outcome versus one who is more resilient. I think that might be an insight that we can grasp onto. For the Wnt pathway, because it's a very difficult pathway to manipulate, it's hard to know just yet about what an intervention might look like. I think a lot of balancing factors need to be considered.
And then maybe one quick follow-up. I know you've done the small molecule screen for neonatal protection. Are any of those molecules that in this large international consortium that you had led provide insights along with for cerebral palsy?
Right, that's interesting. So there were no Wnt agonists or antagonists included in that. As you know, sonic hedgehog agonist is a very promising one for neuroprotection, and probably through stabilization of the blood-brain barrier. But I think that might be a good question to think about for the future.
Thanks, David. That was very nice. It's good to see you back at Stanford again, as I told you earlier. Tried to recruit him once before, Mary, but you focused on the genomic sort of capacity that someone might have, and then suggested there might be environmental interactions. One of the things we've started to look at is a combination of genomics and metabolomics. Have you thought about adding that to this work, so you get a multi-omics kind of signature for risk going forward?
Yeah, thanks, David. So I didn't share the whole protocol, but we're working with the Sanger on this. So transcriptome, methylome,
Perfect.
metabolome, microbiome, and then there'll be one opportunity to get a second set of samples once the kid has left the NICU. We bring them back for neurocognitive testing. So actually, thinking about the discussions today, it would be interesting for us to talk about our data analysis plan and maybe collaborating with Stanford on the paradigms that you're developing, because we are working out those details now, and maybe you've got great experience.
Yeah, very similar approach. That'd be wonderful.
Okay,
I look forward to doing it.
Something, maybe a lunchtime conversation.
Good. Thank you.
Thank you.
Question?
Thank you for your presentation. OB here. So often when we have patients who we think are at risk for preterm labor, we give magnesium. And I'm curious, in your patient cohorts, were there any different signaling in patients who received magnesium for prevention of cerebral palsy?
Okay. So I wouldn't be able to answer the question exactly because we haven't crunched the data to look at cerebral palsy outcomes yet. So I did mention one connection of the prediction of pregnancy outcome study, which is the one that was started by Gordon Smith. Now that's enrolled 13,000 pregnant women with deep phenotyping, and now we will have these linkages to long-term outcome. So we have looked with respect to educational outcomes, but we haven't screened them yet for cerebral palsy diagnoses. We do have that data. But I would think in the UK, the standards for magnesium administration are exactly the same as they are at Stanford. I'm not sure we're going to have a pre-magnesium intervention cohort to look at. But let me keep that in mind and see if I can get back to you.
Okay, thank you so
Thanks.
much. All right. Our final speaker for this session is Dr. Tiffany Scharschmidt. She is a professor and vice chair of dermatology at UCSF in the School of Medicine, and she'll be talking today about the heightened immune tolerance in early life window. Thank you so much.
Nice to see everybody, and thanks for the introduction, Christy, and the organizers for inviting me. I'm jealous of this rich research community you guys have all focused on early life and this maternal-infant relationship, which, as you can see by the photo, is definitely sort of a scientific passion and focus for my research. As mentioned, I'm a dermatologist, so one thing that's been a real focus for me is thinking about peripheral immune tolerance and what happens when we are born into this microbial world and learn to live healthily with the many things in that environment, both food allergens in the gut, as well as the microbiome, both in our gut and our skin and other things. So I'm going to focus a little bit more on sort of some of the basic science that I think is important in understanding this window, and what I think we're starting to begin to understand is really a gradient of tolerance that is very heightened in utero, but continues in the postnatal window. If we think about studies such as sort of peanut allergy as an example of things that could maybe, if introduced at the right window in life, sort of prevent disease and prevent sort of more inflammatory reactions. As sort of illustrated here, I focused in particular on this relationship between our immune system and our microbes, with a focus on the skin. And while there could be some sort of microbial antigens in utero, this is predominantly a source of antigens that happens on postnatal life and exposure, where we're colonized upon birth by these microbes. And somehow we managed to sort of, live healthily with them for the most part. I think we can think of clinical diseases where we think there is an aberrant response to our microbes that is causing inflammation. But something about this early life window really seems to keep the brakes on the system and allow, in most cases, a healthy symbiosis to develop. So, this made sense to me, and scientifically it was something of interest. This is my sort of, unregulated N of 3 sort of case series observational study at home. And for parents in the audience, I think you'll appreciate just sort of the, energy and enthusiasm with which young humans throw themselves into the world around them. This is maybe a mix of oral tolerance and exposure on the skin. But again, it makes sense that there's something, really purposeful in the way our immune system chooses to integrate these many different new antigenic responses that we're looking at. So a lot of our lab is actually focused on sort of trying to simplify this complex relationship using animal models and mice. Actually, the story I'll show you today is mostly human, but I want to kind of introduce some of the concepts that we've sort of observed and sort of confirmed in animal models. So we have studied this mostly in the context of a fully sort of microbiome of a mouse that is replete, but by introducing individual species, Staph epidermidis, a strain studied by Michael Fischbach here, with whom I started my postdoc, is a really common skin commensal. And so we sort of, took the approach years back when I was still a postdoc to do a pretty simple comparison of if you introduce this strain of bacteria to an animal early on, postnatally, just, exposing it on its skin or delaying that until adulthood, and you study the antigen-specific immune response. So we focused especially on CD4 T cells, which have many different, subtypes, but a fundamental decision that a naive T cell would make when it's sort of seeing an antigen and being informed by an antigen-presenting cell early on is whether it's going to become a regulatory T cell or something that's going to sort of dampen or limit inflammation to this antigen going forward, or one of the effector T cell types. And kind of a pretty fundamental observation that this work showed was that if you see this antigen from this commensal early on in the skin, you're much more likely, in this mouse model rather, to develop a regulatory T cell response. And this is something that has ongoing relevance if we kind of extend this study and sort of re-expose these animals to that same bacteria later on. We often do this in the setting of some barrier breach, kind of like scraping your knee, a time when you might want to sort of regulate some of that inflammation to these healthy commensal antigens. We see that animals that first saw that skin bacteria early on are really protected against tissue inflammation and have a re-expansion of these regulatory T cells. But that prior exposure that would happen in adulthood doesn't have that same protection. So again, the quality of this response is really important early on. So this is kind of a model that we've continued to hone and test and try and dissect further, this concept that if we think about at least skin commensal antigens as one of these sort of non-self antigens that we are continually exposed to throughout life, that this early window in that neonatal period is a time in which our immune system is more inclined to sort of make a tolerogenic choice, and that this tolerance is sort of maintained and helps us to maintain symbiosis and healthy tissue immune responses throughout life. So what are sort of concepts emerging in this work as we've tried to understand the sort of underlying cellular biology? We're looking a lot in skin at, how does this choice get made? When you see a commensal antigen, what are the antigen-presenting cells that pick it up? And how do they inform this development of regulatory T cells? One key feature that I won't discuss in depth today is that we can see that certain regulatory type sort of dendritic cells are really important. They're kind of more able to pick up these bacteria, and they're more inclined to sort of educate the naive CD4 compartment to become regulatory T cells. In work unpublished, for anyone really interested in microbes, I'd be happy to talk later. We actually think and can see in our mouse models that the concept that this is a microbial antigen actually in this setting is more reinforcing some of the programs of tolerance in these APCs. And so that might be important as well. But what I want to focus on today is sort of this other compartment that's obviously really important in immunology in this window, this naive CD4 compartment that's really enriched in the developing immune system that needs to be educated and to make these decisions. And so what we're sort of finding again is that this also is sort of these are not the same cells in an adult individual as in a neonatal individual, and what are the types of differences that are in these cells is what we're really trying to understand in terms of their potential to sort of have a tolerogenic response. So I'll talk briefly about some work from Kevin, who's been looking at this in animal models and mostly focused on the work of Laura. These are both graduate students in my group who's been looking at this in human cells. So Kevin just sort of did some foundational work that I think builds on what I just showed, that we can kind of extend what I was just talking about in terms of having a naive CD4 T cell. And in this example, we're sort of taking those cells out of a young mouse or an adult mouse, and we're educating them with the same shared dendritic cell and the same bacterial antigen. And we see that the neonatal CD4 T cell is much more likely to become a regulatory T cell. We can sort of do the same experiment in vivo where we transfer either these neonatal naive CD4 T cells or adult T cells to a mouse, and we give it the exposure to this bacterial antigen. And again, we see that these neonatal T cells are much more likely to become Tregs. So nice to know in a mouse, but I've discussed at dinner last night, and many of us will know that sort of immune development is vastly different in terms of timing and cell types in animals versus humans. And so Laura, when she joined my lab, was really interested in trying to sort of dissect what we could understand about the human naive CD4 compartment and how this differs by age in terms of this regulatory potential. So we would love to study, tissue-resident T cells or other things from different tissues. These are, in healthy individuals, very hard and difficult samples to obtain. So we started with what is the most accessible kind of neonatal surrogate of a T cell, which is cord blood cells. And so she isolated naive CD4 T cells from cord blood or adult cord blood and these were term pregnancies, so sort of no known associations or inflammation ongoing, and just stimulated them ex vivo to sort of activate their T cell receptor. This was without sort of particular stimulation in one direction or another, so not a lot of cytokines or other things. But already we started to notice some differences. We saw that with time, both populations will turn on activation markers like CD25. FOXP3 in mice is a very sort of specific transcription factor for regulatory T cells. In humans, it's also expressed on activated cells, so not as specific. But we started to already see that the cord blood was expressing more FOXP3, these naive CD4 T cells in the adult. And if we looked also sort of at the general quality of the cells upon activation, they were expressing from the cord blood naive CD4 compartment more tolerogenic markers, more CTLA4 or Helios or PD1 or CD25 markers that are sort of thought to be part of the repertoire of different molecules that tolerance is achieved through in terms of different regulatory cell types, including Tregs in our bodies. And similarly, the types of cytokines these cells were making were quite different. The cord blood cells on stimulation made sort of a regulatory cytokine IL-10, whereas the adult blood made IL-2, interferon gamma. So we put these under a more sort of strict, is this a Treg, and how much of an induced Treg or tolerogenic phenotype does cord blood have in difference? And I want to be clear that it's very hard to call anything stimulated ex vivo from human cells a Treg, and there probably are very big differences between what I will call induced Tregs here and thymic Tregs that are coming out in infants. But it's the best way we have to study sort of a tolerogenic potential from these samples. And so to really become a Treg, we think in these induced ex vivo conditions, these cells need TGF-beta and IL-2. So we provided that to both the cord blood and naive cells. They both turned on much more FOXP3 as expected here, but both the percentage in the neonates that are sort of generally positive for CD25, but then more specifically the level of expression of FOXP3 or production of IL-10 was similarly sort of exaggerated here in the neonates. So, it's nice sort of, descriptive data. Is there a functional capacity in these cells that differs based on whether they're coming from a neonatal CD4 or an adult? And there's different ways to sort of test ex vivo, again, the functional capacity of T cells, and in this case, sort of iTregs. Here we sorted these populations after their ex vivo stimulation and mixed them with unrelated donor cells that were both kind of providing the ability to see antigen and then a responder population. And what you're looking for here is the ability of these sort of iTregs to suppress proliferation of the responders. And so what we saw is that cord blood was quite a bit better, even at sort of low ratios to suppressing proliferation of these cells. These are hard assays. We don't know exactly what regulatory mechanism is being used, but it was suggestive here. And then another aspect to sort of look at how sort of committed towards a tolerance program these cells are. One thing that is used is sort of demethylation at the locus of FOXP3, suggesting some level of sort of sustained FOXP3 expression. At the bottom, we were sort of sorting just on CD25, 127 negative sort of Treg cells or enriched for Treg cells from the blood, and we see the most demethylation there. We hadn't actually sorted on FOXP3, so we may improve that when we repeat this study. But you can see already that the cord blood has sort of more of these dark areas, these areas of demethylation. So it's subtle but significant in terms of the relative demethylation here. And we sort of subjected these cells to different stability assays and, compared to 80% when they first come out, if you sort of rest and restimulate them, many of them will stop to express FOXP3, but the sort of persistence of that expression is much higher in the cord blood cells. So what is different here, in this Treg potential? And one question we had is whether some metabolic difference is contributing. There's been work in CD8 T cells and neonates that this metabolic state of a neonatal cell can actually lead to its ability to become effector versus a memory cell. So what is that happening in the CD4 compartment? So we started kind of broadly just looking at metabolic enzymes in these cells, doing CyTOF as a way to measure sort of the relative expression of various key enzymes or receptors in these pathways. And it was pretty clear that the sort of metabolic profile was vastly different between cord blood and adult blood naive CD4 T cells, where we sort of see almost non-overlapping, but slight things here in the red versus the blue. And even if we take away all other surface markers in terms of their expression of CD4, again, we see really nice segregation. And we were starting to see that things like GLUT1 or other things that were somewhat glycolysis associated were upregulated in the cord blood. So we wanted to test that more explicitly with sort of canonical methods such as seahorse. And what we did see is that indeed these neonatal cord blood cells were more glycolytic than their adult counterparts. Their OX-phos capacity was less different. So we started just to sort of see if that metabolic state seemed to have anything to do with this ability to kind of turn on FOXP3 or express some of these regulatory markers. And we did these cultures either in the presence or absence of a glycolysis inhibitor 2DG. And what was interesting is that really, because we had heightened glycolysis in the cord blood, when we added this inhibitor, that amount of sort of IT-reg generation was reduced, but had no effect on the adult cells. Okay, so, there seems to be some difference in Treg potential. There might be some association with metabolic state here. Is there a key regulator that we can sort of identify that might be related in some way to both of these factors? So this is something that's been aware and published a little bit in the past and certainly present on other different cell types, but CD38, and I'll tell you more in a minute about what CD38 is, but it's been used sometimes as an activation marker, other things, is much higher on a lot of the sort of developing immune cells than on their adult counterparts. So I'm looking here just at surface CD38, and you can see in particular that it's quite high on CD4 T cells, though also expressed by other lymphocyte populations in cord blood versus adult blood. I would love if folks had healthy infant blood over the first life to share with me so we could look at this gradient more specifically. Thus far, we've looked, in comparison also at peripheral blood of preterm infants. These were infants born about 5 to 6 weeks premature, and so at gestational age corrected were about 1 week of age, but at a really nice intermediate expression of CD38. And I didn't have time to share it today, but we also in postnatal mice will see an age-dependent drop-off postnatally. So it does seem to be something of sort of a continuum. We also took a look at fetal spleen and saw again that there's sort of a continuum of expression here, and that continuum of CD38 expression seems to track also with some of this IT-reg potential all the way from sort of, this is second trimester, about 20-week fetal spleen naive CD4 T cells versus their cord blood or adult counterparts. So what is CD38? It's a widely expressed and multifunctional enzyme, but its sort of primary sort of enzymatic activity and best described function has been in its role as an NADase. So essentially its activity and levels correlate with reduced amounts of NAD in a cell. And there has been some few prior studies that have sort of tied it to metabolic state in terms of looking at more CD38, and they've said less about glycolysis, but having sort of an antagonistic relationship with oxidative phosphorylation, similar to what we saw. So is CD38 important in this observation we're making about Treg potential, and if so, how? We think it is. We can sort of inhibit CD38 and see this effect on sort of reduced glycolysis in cord blood, but not adult blood. And if we look at sort of effects on this IT-reg potential, under IT-reg conditions, we see a drop in both compartments here, but more so in the cord blood. And also when we look at that sort of stability assay, if we inhibit CD38 during this sort of stimulation phase, we see that those T-regs or IT-regs that are generated are much less stable than if CD38 is active. So CD38 is still sort of a big gap in terms of how this might be connected. So let me just sort of draw out a little bit of what we're thinking. So CD38 is expressed both on the cell surface and intracellularly, but essentially high levels of CD38, as we might see in a neonatal naive T cell, are associated with reduced NAD levels. And what does NAD do in the cell? Many things, and I'm sure we have much more to study and understand about this, but a prominent activity of this is that it serves as a substrate for many NAD-dependent deacetylases. So the SIRT1 family in particular is a group of deacetylases that can work both on histones as well as proteins to deacetylate. And that has been previously associated with acetylation and deacetylation of genes that are evolved in FOXP3 expression as well as glycolysis. So the thought is that, again, this might be a pathway that is tethering this. So try and going through this a little bit, we actually do see that difference in NAD levels associated, as we would expect, with less NAD in cord blood that has the high CD38. And it's hard to know in these sort of ex vivo assays physiologic levels of NAD and what the change are. I admit these are subtle, but we do see that NAD is changed a little when we inhibit CD38. So we've explored a little bit more directly SIRT1 as maybe a downstream mediator of this. So looking again and sort of cord blood at the left versus adult blood, we see this difference in iTreg potential. And if we kind of, supersede and totally jump past the NAD and instead directly activate SIRT1, so we think that SIRT1 is more active because of higher levels of NAD in adult blood, we see that, further activating that can really reduce the amount of iTregs. In contrast, inhibiting it actually doesn't sort of further increase this in cord blood, we think, because SIRT1 is really already limited by low NAD levels, but it actually can improve the iTreg generation in adults. So how might this happen? I mentioned two things, and I'll be very quick here, but essentially this be happening through sort of change in histone acetylation that might sort of lead to differential accessibility of the FOXP3 locus and its expression. But there has been some prior work showing that, again, there can be direct acetylation of the FOXP3 protein by SIRT1. And so here sort of that is antagonistic. If you have more acetylation, it essentially promotes stability. So more SIRT1 in this case would lead to more FOXP3 degradation. So we've just started to look at this. We actually don't see much in the way, and this is not specific to the FOXP3 locus, but a lot of differences in histone acetylation. But we do see these differences actually quite dramatically in the level of protein acetylation for FOXP3. So again, we think that this balance of SIRT1 here downstream of CD38 could have an effect through glycolysis as well as through this sort of direct action on FOXP3 protein. So just to sort of wrap back up where we're looking at, I think what I've sort of learned thus far from our group is that, every immune cell type and compartment sort of has a gradient of tolerance. And I think really dissecting that fully and understanding where we can maybe, better enhance those tolerogenic programs in healthy infants, infants at risk for disease, inflammation, or allergy has great potential. What I hope you've sort of just taken away from today is that we think these naive CD4 T cells are one area that really, have this gradient, and that CD38 as well as glycolytic dependence is one thing that sort of helps to mediate their differential tolerogenic potential. So I think for this group, I would love, input and thinking on, this is again something that we're measuring sort of at birth in the cord blood signature, but we have really, just sort of starting to make this observation, no ideas yet about, what is the effects of, gestation and effects of the mother in terms of changing this rheostat for tolerance in the newborn immune system. So with that, if there's any time for questions, but would welcome during the break as well. But thanks for your attention.
Hi, that was awesome. Really interesting talk. I'm interested in, if you were to introduce in this, neonatal mouse, both either, a pathogenic microbe or a more commensal type microbe versus in, one of your adult phenotypes, if you would see a different response from these CD4 T cells.
Yeah. We do. We did some of that work comparing Staph epi to Staph aureus, and we see that there is more limited Treg generation of Staph aureus, which we thought, what we showed is that might be due to heightened IL-1 that kind of is antagonistic and more sort of shuttling T cells down to Th17 response. So I mentioned things like TLR2, which is conserved across many gram-positives or other microbes that could be sort of a general rheostat for tolerance, but that doesn't mean that there aren't sort of alarmins or other things that could undermine this that helps us sort of determine, again, what is something that we might not want to sort of generate as much of a tolerogenic response to.
Okay,
Yeah.
Thank you.
Very nice presentation. I was wondering whether you have begun to look at differences between, say, an very early preterm birth cord blood profile and the term infant. We know that Treg expansion in the mother is important for maintaining tolerance. So these same kinds of things are happening there, and I'm expecting that there would be differences that you'd be able to see. And then the risk profile for these kids later for the kinds of things you're studying would be also then different. Is that?
Yeah, we have yet to. I mean, and I would love to collaborate with those who have more access to those samples. We were able to get through the preterm birth initiative a couple of these samples for this study, but haven't been able to apply it to a broader cohort in terms of looking at cord blood, by age and sort of, cause of preterm birth as well. I think would be super interesting.
Our visiting speakers have given me all kinds of ideas that will be good to explore. Thank you.
The symposium really is just full employment for David Stevenson. Great talk, Tiffany. Question about metabolomics. So we have the MCHRI has this whole metabolomics screening at newborn. Are there other metabolites that you think also play big roles in affecting this long-term memory, both central and I'm assuming peripheral tissue-specific memory?
Yeah, I would love to look at that with some. We definitely have not done like metabolomics on cord blood, and it sounds like that is part of a lot of these longitudinal cohort studies. We're focusing on the metabolic state of one of the immune cells there, and so whether that be reflected kind of in the metabolome more broadly from the serum or other areas, I think is yet to be looked at. But I do think we're looking with some other groups more broadly at metabolic states and tissues of a wider array of immune cells. And it's actually interesting that, even more so than the tissue, meaning gut versus skin, while there are differences there, the main factor we see different is age. And so I think just understanding metabolism and its role in early life immune function and how that shapes that sort of, not just diminished but distinct function will be a really exciting area.
And then can you just comment on what you think the adult impacts of this are in terms of either peripheral tolerance mechanisms for what diseases do you think this plays out in? Because I know you think about that too.
Yeah, I think it's hard to sort of think totally in humans. I think there's still we need more understanding of how much peripheral Treg generation is important in long-term tolerance. But for me, especially things like atopy, asthma, food allergy, and that sort of thing, where we're talking about non-self antigens would be really important. And those are sort of the and atopic dermatitis that I know we think about a lot. I think more broadly and maybe less easy to grasp, but thinking about this inflammation in tissues that might also happen kind of in preterm birth or sort of, infants that are have these other, events that happen in that perinatal or postnatal window. This might manifest in other ways in terms of tissue injury that I can't even think about, but would love to sort of, individual organs, like how does the sort of rheostat of tolerance there change based on how sort of primed the immune system is to be tolerogenic. So, thank you.
Okay, great. Well, that concludes this session and starts the poster session for the next hour or so.